Hello. This is our question of the week. A 37-year-old G1P1001 delivers a 38-week female infant via spontaneous vaginal delivery. At birth, the infant is noted to have slanted palpebral fissures, a single palmar crease, and a wide gap between the first and second toes. A murmur is auscultated on cardiac exam, and a congenital heart defect is suspected. Which of the following is most likely to be present on further evaluation? A, narrowing of the aorta. B, severe regurgitation between the ventricles and the atria. C, pulmonary stenosis with an overriding aorta. D, an abnormal connection between the pulmonary artery and the aorta. So this question requires a couple of steps. First, we're given a bunch of physical exam findings that have nothing to do with the heart, and we're told that the kid has a murmur, but we don't know what kind of murmur it is. We don't know if it's systolic or diastolic, continuous, if it's harsh, if it's machinery-like. We don't know anything about this murmur. We just know that it could be a murmur. A murmur can be anything. A murmur in a baby this age can be normal, although it does say that congenital heart defect is suspected. So we have a kid who has a bunch of abnormal physical exam findings and who has a murmur. So we need to figure out what the unifying diagnosis is here. So what's going on? What do all these physical exam findings mean? What syndrome is this associated with? Once we figure out what syndrome the kid has, then we need to figure out which the most likely congenital heart defect the kid has based on that syndrome. And then finally, because the question isn't just what's the most likely congenital heart defect, we need to know enough about the features of that particular heart defect to be able to figure out which of these features would be present on evaluation. So this is a multi-step question. So the first step is to figure out which syndrome this kid has. And we have some hints here, some pretty good ones. So at birth, the infant is noted to have slanted palpebral fissures, a single palmar crease, and a wide gap between the first and second toes. So those are all three very particular physical exam findings that when taken together, you can be pretty sure they have one particular syndrome. And that syndrome is trisomy 21. Trisomy 21 is a syndrome that's caused by having an extra copy of chromosome 21. It's more common in advanced maternal age, and advanced maternal age is over 35. So that's actually another hint on this question because the mother is 37. So that's another hint that this kid might have trisomy 21. So trisomy 21 has some very characteristic physical exam findings, some of which we noted in this kid's exam, including this typical facies with epicanthal folds, which are these folds kind of on the, let's get this one, these folds that are on the medial part of the eye, as well as slanted palpebral fissures. Sorry about that. As well as slanted palpebral fissures. On the eye, you can also have brush field spots on the iris, and you can have small hypoplastic ears. On the hands and feet, you can see clinodactyly, which we didn't mention, but this kid might have it, and then a single palmar crease. So on the hands, you can see that single palmar crease. And in addition, on the feet, you can see this thing called the sandal toe deformity, which is a wide gap between the first and second toe, like where the strap of a sandal would go. So all of those together, as well as, some other findings, some problems with tone, some problems with obviously later on cognition and things like that. You can see those as well on exam in a child with trisomy 21. But obviously cognitive defects are not going to be picked up in a newborn, which is what this baby is. So we know which syndrome this baby has. So now we know the baby has trisomy 21, and we know that the baby has a congenital heart defect, or that we suspect a congenital heart defect. So what congenital heart defect? All we know is that this baby has trisomy 21. If we say trisomy 21 plus congenital heart defect, what is the most likely congenital heart defect that this baby has? It's an endocardial cushion defect, which actually goes by a lot of names. Sometimes it's called an endocardial cushion defect. Sometimes it's called an atrioventricular septal defect, or an AVSD. Sometimes it's called a common AV canal. They all are referring to the same thing. And so the reason why it's called an endocardial cushion defect is because that's talking about the problem embryologically. So normally your endocardial cushion, your heart kind of looks like this, where you have some atria and ventricles, but they have this big connection in the middle. And normally you form an endocardial cushion in between all of those, and that kind of grows up and down, and it's kind of separates off your right side from your left side. So you have these two separate circulations. And it also helps to develop this part of the valves as well. So, or to develop like, you know, the connection for the valves. So when your endocardial cushion does not form, you're left with this kind of embryonic form of the heart, which is that your atrial septum just kind of ends up here, and your ventricular septum just kind of ends down here. And you have this big area of connection, not only between your atria and your ventricles, but between your left side and your right side. So that causes some problems hemodynamically, right? Because you really want those two circulations to be separate. So there's a couple of problems that occur, which is that, let's follow what happens to blood. Blood goes into your right atrium from your SVC and your IVC. And then it goes through that common AV canal into the right ventricle. And it could go across if it really wanted to, but it probably doesn't, or it doesn't very much, because remember when blood has a choice between two or more paths, it will choose the path of least resistance. And the right side of circulation is a lower resistance circuit than the left side circulation. So it's going to prefer to go out into the pulmonary artery more than it's going to want to go to the left side of the heart, which is that higher resistance circulation. So enough of that blood goes into the pulmonary artery, and, you know, it goes to the lungs, and then it eventually comes back into the left atrium. And then it goes into the left ventricle, and from the left ventricle it can go, or it goes across this atrial septal defect into the right atrium. And then from the left ventricle, it can go a whole bunch of places too. It can go out the aorta, but again, when blood has a choice and it can go down the path of least resistance, it will. And the path of least resistance is going to be going to the other side, right? Into the right ventricle, maybe into the right atrium. There's a whole bunch of stuff it can do. So this is obviously a big problem. You've got probably net a left to right shunt, depending on there are more specifics about this that are definitely beyond the scope of this question. But you've got blood that's not, your two circulations aren't separated. And as a result, you've got blood that's not going where it needs to go. So this is a problem. So let's go back to our question. We know the hemodynamics of this. So which of these four things is this kid going to have? Well, we can either do this by process of elimination, or we can do it a little more empirically. So let's do it a little more empirically. Let's think about what's going on in this heart. So this kid has, we know that he's got blood that's going all over the place because the sides of, well, actually, I guess it's a female infant. So the sides of her heart are connected to each other in a way they shouldn't be. But there's another important thing here, and that has to do with the valves. So what do the valves look like here? They're pretty abnormal, right? Because normally you'd have an annulus that has, like if we're looking on the right side here, we'd have our tricuspid valve. So normally we'd have our annulus, and our annulus is anchored over here in the middle. It's anchored to to the structures that come from the endocardial cushion. So if we're missing the endocardial cushion, we're missing those connections. And what we wind up with is kind of a common valve. In addition to having just like one big chamber, we've kind of got one big valve with that chamber. But look at those leaflets that we have here with this big valve. The leaflets are like this. Is this going to be a good valve or a bad valve? This is going to be a pretty terrible valve, right? Those leaflets cannot coapt in the middle to separate this out. So this big valve cannot close. So what's going to happen when our atrioventricular valve can't close? What's going to happen when we have ventricular systole, when we squeeze our ventricles? Blood is going to regurgitate, right? It's going to go back up, because remember, blood has a choice. And when we squeeze on our ventricles and we increase the pressure in our ventricles, that blood wants to get out of those ventricles. So it can go a couple of ways, you know. Here, it can definitely go out into the arteries. It can go, you know, it can go to the other side if it wants to. But it also wants to go back up into the atria, right? Because remember, while the ventricles are contracting, the atria are relaxing. So it's atrial diastole, and there's really low pressure and low resistance in those atria. So a good chunk of that blood is not going to go out or across, but it's going to go back into the atria. So that's a pretty big problem, right? You're going to have a huge amount of regurgitation between those ventricles and those atria. So there's your answer. You have severe regurgitation between the ventricles and the atria. And we could do process of elimination as well by looking at the other answers. So narrowing of the aorta is associated with which congenital heart defect, or is the defining feature of which congenital heart defect? Coarctation of the aorta, right? Which can be associated with genetic syndromes, but not trisomy 21. And pulmonary stenosis with overriding aorta, those are features of which congenital heart defect? Tetralogy of Fallot. And tetralogy of Fallot has a very high yield association with a particular congenital heart, with a particular genetic syndrome. And which genetic syndrome is that? DeGeorge syndrome, or 22q deletion syndrome, not trisomy 21. This kid does not have DeGeorge. And then an abnormal connection between the pulmonary artery and the aorta. So what is that? What is the name for an abnormal connection between the pulmonary artery and the aorta? A patent ductus arteriosus. So a patent ductus arteriosus is the ductus arteriosus is a normal part of the fetal circulation which connects the pulmonary artery to the aorta to be able, so that you can shunt blood away from the lungs and towards the rest of the body. And that ductus arteriosus closes. But when does it close? It takes a couple days, right? So if this is a newborn, like a baby right at birth, only a few minutes old, they very well might still have a patent ductus arteriosus. But here's the thing. It's not abnormal yet because it's not supposed to have closed yet. So if this baby does have a connection between the pulmonary artery and the aorta, which she probably does, it's not an abnormal connection. It's a very normal connection. So that's kind of like the trick answer in this question. So that's it. There's a couple of ways to figure it out. It takes multiple steps, but the answer is that this kid has an endocardial cushion defect and therefore has severe regurgitation between the ventricles and the atria.